Welcome, everybody, to Community Connected Health. I'm your host, Skip Lowe, and joining me, as always, is
Colton Storla.
Oh, my good friend, Colton Storla. Glad to have you back here. Really excited. Just a lot of momentum after the last couple of episodes we've had, so really thank you for your input. We love questions. We love the challenges. I'm super honored today. I've got another good friend of mine here. I've got Rich Green, CEO of DMOS in Des Moines, Iowa, Des Moines Orthopedic Surgeons. And I've known Rich for quite a few years and some folks on his staff that we've been really close to for many years as well. Yep. So speaking of challenges, you guys have challenged us and always ask the right questions and just finding better ways and better methods in what we're doing, because we know insurance is just so compelling and such an interesting thing like reading history. So before we jump into things, you've got a really great background.
Unique.
Yeah, I want to know a little bit, where'd you grow up? I love your father's story, and
sure,
I think it speaks to what you do every day.
Sure. So I grew up in Chicago and then Memphis, Tennessee after that for, about 18, 20 years. Moved to Iowa, moved to Des Moines in early 90s, 1990, in fact, to go to physical therapy school. And then I was a physical therapist for 25 years working in health systems and private practices, things like that. And Des Moines Orthopedic Surgeons wanted to start their own physical therapy clinic. So they said, hey, Rich, will you come out and help us pop these up, which I did. And I use the word I very loosely. My team and I did that, not just I did that. And we did a great job, got it going in about, 16, 18 months. We had 25 therapists and 3 clinics and got it rolling. And the administrator for DMOS had stepped out at that point, and they asked if I could come in as an interim, which I did, and then took it from there and hired some super great people. That rule of leadership of hire smarter people than you, that absolutely applies. There's absolutely no doubt. So I've got an A1 MVP team that works together with us, and we've moved forward, and we've gone from 3 buildings. We're opening Norwalk up. That'll be our 5th or 6th now. We've grown from 280 employees to 350. Along the lines of this topic, we have completely revamped our benefit program, which was a tremendous learning experience from top to bottom. And grown in terms of physicians and access points within the system, and really with the goal of providing access for patients so they can get where they need to get, so they get the best care and the right care, right timing. And really, as our board president says, Dr. Nick Honkamp, we got to bend the cost curve and figure out things to do that with. And we've done a lot of those. I'm sure we'll talk about that a little bit today.
Yeah, no, great teaser alert. And kind of my opening salvo is to talk about your dual role, because you're a CEO of a medical clinic, so you've got to manage these brilliant people all day long. You do have a great team. I'll second that notion. So, we work with Renee Pyle. So she's been called out here. So I'll make sure that's read and going across the screen for everybody. But she's got a fascinating background. She was with Barnum and Bailey Circus and worked with HR. She loves trains like I do. So we really hit it off a number of years ago. I've known her for over 25 years. But also she's got a background. She knows the law.
Yeah.
And that's what you need to have on your team, that people are going to dive in and find out, what are we doing? Is it going to meet the requirements, et cetera? So, but that triple role thing, you're CEO, you got a provider background, and then you're trying to manage all the costs for your organization. So congratulations on the Norwalk announcement.
Yeah, thank you.
So this is a great opportunity to put that prime time for you as well. And then real quickly, tell me about your sports injury urgent care program that you have, or your official name for that, where you've got to walk in.
We have really looked at our urgent injury clinics as the best access point for patients. We know that any patient out there now is a consumer. They're not just a patient. We don't walk around like lemmings and go where people tell us anymore. We look things up. And being able to have those access points close to people as a walk-in has really been effective. And we've noticed our fastest growing ancillary service, physical therapy, our ASCs, et cetera, MRI, has been our urgent injury clinics, and people coming in and getting care. And what we see with that, and what I learned, part of that dual background when I was a physical therapist and you work in the primary care space, is you oftentimes see people take this path that's traditional, but it's not the best.
Yeah.
And the best is getting to the right people in the right time. Well, if you have an orthopedic injury, start with orthopedics. It's not that complex, right? So
Yeah.
Maybe you can speak to that a little bit. So if someone had an orthopedic injury, I mean, everyone's first thought is let's go to the ER.
Yeah.
So what's the difference?
Yeah. And that's just traditional, it's what we grew up with. We need to go to ER because it's something really bad. Well, really in an MSK and orthopedics, the only thing that really needs to go to the ER is if the bone is sticking out. Yep. Basically, it's a big trauma, and we do see plenty of that, and those are very serious. But if somebody has a really bad ankle sprain, or they have a knee ACL sprain, or they've dislocated their shoulder, oftentimes you can be treated at a center like an urgent injury clinic. You want to talk about decreased cost. Holy cow. Every patient that walks in our urgent injury, it's $5,000 less than what it would have been if they went into an ER. And we did, I don't know, 15, 18,000 urgent injury clinics or urgent visits at our urgent injury clinics, couple places. So you can imagine that.
Oh yeah.
Extrapolated over time, and people get the care. They're able to get in and out. And if it's something that requires a physician, we get them into that really, really quickly. There's a great statistic that we're putting out that, really only 20% of patients that go into an orthopedic surgeon's office require surgery. Right now, only about 18% of the people that go into DMOS have surgery.
That's your stats.
And that's our stats, right? National's 20.
I'm picking on you on purpose.
Yeah. Yeah. Our stats are 18% that require surgery. So if you don't require surgery, why are you paying so much to see a surgeon? Let's see a really experienced PA or PT that can diagnose that at 20% discount. And that's how we bend the cost curve, doing things like that.
We like your thinking.
So you got the urgent care, you got the PT, and then we talked about the orthopedic surgeons. So what do you guys specialize in from a surgery standpoint?
We are highly specialized. So the advantage of having a big group is that you can have guys that are doing what they like to do, what they're really good at, and then what they focus on. So they're doing it over and over and over again. And if you do things over and over again, you get better at it and more efficient, right? So we've got our spine clinics. We've got 3 spine doctors. We've got 8 to 10 joint physicians that do total joints. We've got 5 sports medicine guys. We have a couple general. We've just recently, in the last 3 years, propped up our traumatology program. We have 2 just world-class traumatologists that work out of IMMC at Methodist. Methodist is one of only 2 level 1 trauma centers in the state, and we've got 2 traumatologists down there to take care of that. And then we've got the largest hand division or hand practice in the state with I believe it's 5 now. Hand guys. So we do pretty much everything. And I would be amiss if I didn't talk about our foot and ankle guys. We got 2 of them.
Yeah. Well, you know what? Insurance brokers are kind of traumatologists too, aren't they? Come to think of it, sorry that name was taken, but no, this fits right into our ecosystem and our goals and mission. And as people have listened to these podcasts and as we're educating the world and, we're all kind of on this great big magic carpet ride together, this fits in so with the DPC. And I think I mentioned to you, maybe it was last week, that we actually had a patient experience where they had tried a couple places and they went into your sports trauma center and urgent care center, and they said it was just an amazing experience.
Fun to hear, yeah.
And I think that was an ingenious idea, to say the least.
Wasn't mine.
Well, I feel like there's nothing worse when you are sick or you're broken and you're going to a doctor or a facility and it's just trial and error, and error, and you're not getting answers, and you're multiple visits, you're taking time off work. And so to your point, right place, right care. Yeah,
absolutely. And, one thing we preach from the administrative level to the physician level to everything within DMOS is the commonality of anybody that walks into our building is that they're fearful. They're scared of something. They're scared that I'm not going to be able to play again. I can't work. I'm going to miss an activity or whatever. And when you take it from that point, and the person that checks you in understands that, and the person that takes you back for the X-rays understands that, you really form a bond. And we want to respect that, of course. But we really want to be able to get the answers, be clear, concise. What do I have? What it's going to cost? How long is it going to take for me to get better?
Yeah.
Those three things. And we try to emphasize that with
Yeah.
folks.
Well, and it's really important because I've been saying this over and over the last couple of years, and that is people have gone to the emergency room or they've gone that normal pathway of seeking care, and then they get the bill in the mail and they say, I'm not doing that again.
Yeah.
And then the next time they show up, they're an absolute train wreck. So it's getting that quality access, care at the right time, at the right price. Again, it bodes well for what we're trying to do is get that care at the lowest net cost. So from an employer standpoint, Colton, I'll let you go ahead and take the next part of this, just talking about their benefits.
But no, I kind of want to talk about.
Perfect.
You know, you mentioned the ASC portion, and some of our listeners probably aren't aware of that term, and so if you want to speak to the advantages of having one and how that can also help employers.
So yeah, thank you, because I do sometimes speak in nomenclature that's doctor-ish versus humanish.
We do the same thing.
Yeah, so an ASC is called an ambulatory surgery center, and it's a freestanding building that you can do surgeries in. And 20 years ago, this was your common arthroscopic procedure and maybe your carpal tunnel and things like that, whereas now we're doing full joint replacements. We're doing spine surgery, doing a lot of things, and that helps in two areas. One is hospitals are big; they have a lot of things going on, and it's really hard. They're great they're good at a lot of things they do. We need hospitals. I don't want to let that get lost in this conversation, right? But when you can hyper focus on doing one activity like MSK surgery, you can get better at it because that's all the nurses are doing. That's all the techs are doing. Obviously, it's all the doctors are doing. So pulling those cases from a hospital to an ASC, to a surgery center, one, there's a cost of care difference. There's usually about a $10,000 difference in having it done at a hospital versus a surgery center. And then two, because we're so hyper-focused on what we're doing, our processes get better. It's safer. Infection rates are lower. Patient satisfaction is much higher. And then the technology catches up with some of the things like I would have never imagined when I went into PT in the mid-'90s when I was practicing that somebody could be discharged the same day to go home with a total joint. That just still blows my mind. But what's caught up is the technology where the incisions are smaller, the guides are better, the patients are getting in and out in under an hour, the pain management afterwards is better. So the patients leave and they're like, man, I feel great. So we're able to do more in surgery centers, and that helps, again, with the quality and the cost of care. And we're seeing a tremendous – and this isn't just Des Moines. This is nationwide in this shifting of cases from one area to another.
Yeah.
Super important because when, we look at employer plans from a data standpoint, cancer, high claim category, cardiovascular disease, and then MSK. And that category is growing, exponentially. And so if employers and consumers know that they have this option to either go to an independent orthopedic practice, an ASC, have a better experience, save themselves some money, save the employer some money, which ultimately obviously is going to help with the downstream, effects of their health insurance premiums, so on and so forth.
Correct.
Can you speak to your involvement with Ortho Forum?
Sure.
I know you just came back from
we just had
that event.
our big meeting here
maybe
just
some
a couple weeks ago.
Takeaways from that meeting?
Those are always great meetings. Orthopedic Forum is a group of 100 and I want to say it's almost 160 now, privately owned orthopedic practices across the country. They vary in size from 5 physicians up to 150 physicians. We've been part of Ortho Forum since 2013. And it's just a great place to go as groups and say, hey, what are you doing? What have you heard? How are you doing this? And you really can kind of progress yourselves. And we kid, there's 3 Ortho Forum practices in the state with ORA, Steinler, and ourselves. Actually 4 now. Capital Orthopedics is in that as well. And we steal from each other all the time. I mean, our urgent injury expansion came from Ortho Forum. Our DME processes somebody else took from us. We got all these other kind of things. So that's one thing is the operational side. The second side to that is Ortho Forum has formed what's called the Ortho Forum Value Network, which is a separate organization from Ortho Forum that provides a full MSK network at the 47 states that we're in. happily serve on the board of that organization, and we're really trying to get the word out and then be able to plug that into plans. That if you're an employer that has 18 states, say you're a large grocery chain that has 18 states around us, you don't have to just come to DMOS because it's impossible for somebody from Wisconsin to come. But you can go to a same group, very similar group in Wisconsin that does very similar things. And we're seeing some traction pick up on that. And we're hopeful that in the next 4 or 5 years that becomes a force, because that takes a lot of the middlemen out of it. You're going right to the person providing the care when you go through OVN. I think that's really critical, really important.
Should we talk about some of those middlemen?
I'd be happy to. Yes.
Well, just a second here. I think it's worth noting. You figured out that you're only going to get stronger together, as opposed to trying to do your own thing. And the efficiencies that has been brought into the healthcare system is second to none. But this OVN is really a compelling idea that's out there. And I know we're using acronyms and we're talking in a different language at times during this discussion. But as we get into the putting your employer hat on, the advantages of working, having that connection with your partners across the country. Back to the discussion you had or your meeting with the OVN, was there anything that was just kind of glaring that's happening in the industry that's like you see like this next level?
I honestly think we're at a tipping point in our industry. And I'll probably answer both of your guys' questions at the same time.
Yeah, we come as a match set.
It's kind of bookends. I think we're at a tipping point. And the tipping point has been driven by the cost of premiums. And you guys have talked about that in your previous events with things like this. And we're looking for alternatives. And if a group like large MSK network across the country, third highest spend, can show that, hey, if you go here for your surgery, it's going to cost this. Here's our pricing, which we have 48 CPT code prices, so 48 procedures we have already published. So we're relatively transparent with a lot of our prices over these other groups. I think that's where you're going to start to get some of that. The challenge is, I think, just as Americans, we're generally paranoid of anything that's new. Like, okay, that's like DPC. DPC is fantastic. We put DPC in, employer hat on our side with the benefits. It was wonderful. When we tell our employees you can go here for free, they're like, no, you're not. Nothing's for free. It took 3 years to get, and now they're getting it. Well, it's not free. We're paying for it. But it's free to you, and they get it, right? So I think that's a little bit of the mismatch, and maybe a little bit of the challenge when we go out as a group. Is you can't do that, not over the entire country. But we're seeing that traction being picked up, and as time rolls through, brokers like yourselves, which are hard to find, by the way. Not that
we already we hit your GoFundMe account.
I know. Good. But brokers that aren't in it for the per member per month, we're in it to bend the cost curve. And groups like Health Rosetta is a great place to start because you find those brokers. That's where the change is going to occur. I'm rambling a little bit, but that's where the change is going to occur, and that's where I think OVN hooked into something like that is going to be a powerhouse.
Well, I feel like, to Skip's point, we're better together in the fact that you have a group that you can go to and collaborate and say, hey, we're all experiencing this across the United States. We need to do things differently. So we're trying to push our mission, you're trying to push your mission, but, from Skip and I's standpoint, as we're meeting with employers, we're trying to shift their focus from, okay, quit buying insurance and you need to start buying healthcare. And remove as many middlemen as possible. And, with the Ortho Forum Value Network, those things are possible because that's what we want to do is remove all the profiteering middlemen, remove the margin, get people to high quality health care that costs less.
So let me ask you guys a question. How many people understand that?
Not many.
That's the challenge, isn't it?
Yeah.
We get it because we've been looking at it. I've been blessed enough to be on the employer side and the provider side, so I get this 360 view, right? It took some time, but I get it now. How many of the people that you talk to actually understand
it? It is, a hard thing to wrap your mind around because sometimes when we are talking to employers and these are all new concepts to them, they're like, well, is this new to Des Moines? Is this new to Cedar Rapids?
Yeah.
And no, it's happening all over.
Yep.
You know, these little, you know, as our friend Matt Ort would say, these little brush fires. And, you know, through education, and, you know, that's the purpose of this podcast, is just to get the education out there. They don't just want to hear from us. They want to hear from people that sit on your side of the table that
Sure.
in healthcare. So that's why your point of view is just so important.
Well, that mission alignment also includes that when we do develop these relationships where you put your bundles out there and we start working with different platforms, we just got you lined up with another one a couple of weeks ago, host care. And so your bundles are going to be out there. So as the nurse navigators that are connected to the DPCs and you're through the OVN, you're going to get pinged for a national employer. You're, again, in 18 different states at this point, and it's going to keep growing. But the mission alignment for the broker side is, at least from, I am going to speak for you, is that, you know, once we build these things out, then it's for everybody to enjoy, right? Because you can't build a tree, right? You got to plant the seed, and you got to work really hard at it. And I think that, you know, we started coming up with these concepts and ideas. We're like, oh, we're going to go like a scalded dog through this thing, and we're going to blow it all up, baby. But, you know, it's taken a long time because it's been a too good to be true.
Yeah.
And we have, you know, I've always said we're kind of like pioneers, and we got, you know, there's a lot of varmints out there that are trying to, you know, say this is not going to work. And so there's that doubt, and healthcare is an emotional transaction, and people think their insurance guards are their doctors. And when that happens, it's really hard to get through to them that this is going to be great. And that's why I said before we even got rolling here is the testimonials. That's the thing that you can't put the cork on.
Right.
Is when the patient says, this was great, thank you so much. That's the difference maker that has never happened with all these shiny brochures, and we're going to put a wellness plan in, and we're going to, you know, we've been through all these iterations.
Right.
And we're going to make it better, I promise. And so, you know, we've run out of material. And so that's why we were saying, well, it's time to either retire or innovate. And so it's that alignment is what I'm getting to. With the brokers have to be aligned with the providers. And when you do that, you're all at the same side of the table. And that's the other thing. It's like, that's what calms down a lot of these doctors' offices, or clients, is when we're like, well, meet our DPC. He's here to, you know, we'll talk about the insurance when it's our turn, but we want to talk about what the experience is going to be for your employees.
I think you're getting the pressure too. What's meeting that, why I call it a tipping point, is as an employer, that was our journey, is we had to do something. I mean, you guys came to us and said, oh, if you go to the really big building in downtown Des Moines that has blue facade to it, and it's going to end up costing you like $1.2 million next year. And we looked and went, we can't do that every year, more than what we're paying. We can't do that every year, because then we can't put in an urgent injury in Norwalk that services people. We can't give raises out to employees. We can't do all those things. So we took that journey of, well, let's start with DPC. Let's go self-insured, which was incredibly scary for a group that's never done it before, because the first thing you think is, oh, my God, if everybody gets sick, we're done. And could that happen? Sure. But does it happen? No. And there's a lot of other things you've taught us that go into putting guardrails on that. But once we're able to put in a good network, DPC, and then a good network that our employees could go to, and then the most important part was we got our PBM. What was the number we saved our first year on the PBM? Do you guys remember? I want to say it was like $400,000 compared to what it would have been. It might have been higher.
I think it was like. It was $322,218.
It was a lot.
It was like $300,000, Rich. Yeah.
Yeah.
It was like, that's how many jobs is that?
It was a lot.
Yeah.
And we've seen that every year. So from an employer standpoint, when you hear something like that, the other CEOs that I talk to in other businesses and industry go, hey, wait a minute, how'd you do that?
Yeah.
And then you say, okay, we're going to have a conversation. You can't fall asleep.
Yeah.
You have to be, you got to be focused. We'll take this little bits at a time, right? Maybe over 3 or 4 days, but we'll get it done. And then once they get it, they're like, oh, we can do that.
Yeah.
Well, I think some employers get stuck, you know, looking at their renewals 12 months at a time, and you need to look at it as a multi-year approach. Because to your point, you know, if you're constantly increasing your costs every year, you can't innovate, you can't grow, which means you can't serve the community that you're in. So there's all these other downstream things that people don't think about, and I think employers are in the same boat. You got a manufacturer that has, 300 employees and they're continuing to see increases. Well, that's less pay raises. That's, maybe they want to do an expansion and all these other things in their community. And I just don't think people think about how much just renewing every year just hurts their business and their people.
They're stuck in the process, right? We're gonna come meet with you in August. Mm-hmm. We're gonna give you our end of year results in October, and we're gonna come to you in November and say, here's the price. You've got 20 days to sign this piece of paper.
Yeah. Mm-hmm.
And they're going, wait a minute, I can't negotiate? No, you can't negotiate. Yeah. This is what you have to do. And then they get pissy for, hopefully I can say pissy, they get pissy for however long, right? And then by February it goes away and they don't think about it until August of next year.
That makes me think of, I just had a recent conversation with an employer, and I feel like some employers just don't think it's possible. And
Correct.
This is just how it goes. We increase our premiums, or we eat the costs as the company, or we raise deductibles. And this particular employer, they've got a very low deductible. Their costs are continuing to rise. Not high earners, so they recruit and retain off their benefit plan. And she was like, well, I think we need to add a high deductible health plan. And I'm like, you're going to try and move people from a $500 deductible to at least $1,800 is the minimum high deductible health plan. I'm like, are you doing that because you think it's a good strategy or because your costs are going up? She goes, well, our costs are going up. It's like, well, what if you were able to do things to reduce your costs so you didn't have to move to the high deductible health plan? It's like, oh, that's a good point. But some people just, I think, are conditioned to, hey, costs are going up. It's reality. It's happening everywhere. We just have to accept defeat.
It's the only lever they know how to push, right?
Yeah.
And then eventually the deductibles get so damn high they can't do anything with them.
Yeah, everything's going well until they get sick. And then they're going, what did we get ourselves into? And so you've got also a disconnect on the financial well-being from your C-suite of organizations versus someone that's making a lot less. And so it's like, well, hey, Rich, I got a great idea. We're going to go ahead and put everybody on a $5,000 deductible in your plan. But if you're making over a certain threshold of income, you get a $300,000 deductible, because that really is kind of the exchange rate for people, because they're suddenly hit with 40% of their income to just hit their out-of-pocket maximum. And they also have to pay their contributions for their health plan. So now we're having adverse selection. People are just jumping and bailing. Yeah, and I think it just comes down to this is just too good to be true. And I think that there's a slow adoption rate. We're getting that momentum out there. And again, and the key here for me, speaking for me, is the testimonials, because that's the thing I never saw, and the data. And you're right, yeah. Coming in August, how are the kids? Hey, let's go do this or that, and go out to dinner, whatever. I don't golf, in case you ever ask me. Just ask Colton.
Understood.
I'm great at a lot of other things.
It's hard to golf with a suit tie on.
But my point is that now we have the data. We have a lens into seeing things, and because that first big jump leap, because sometimes it's like jumping off 50,000 foot ledge. But it was
actually hold your breath for 12 months.
Yeah, and it was more like, it ended up being more like 5 feet. But we also were able to identify high utilizers, not picking on your group, but others, and we're like, oh, we have an entirely different curveball strategy.
Yeah, we have some high utilizers.
We have these medications, which is they're mercenary priced, are going to hit you for $1 million. And so we were able to evacuate that risk from your plan through another strategy and say, okay, underwriter, come back and look at this now without these people. That's the power of having the data. It's a data-driven business, and it's hard to get data, let alone getting,
You can't. Face it. If you're with a fully insured group, you're not going to be able to get data. We tried to do it for 5 years, and we would get it. It was some scant, whatever, garbage. But the data we get now, being a self-insured entity versus what we got with fully insured, is night and day. And to your point, we can do things about it. We can go,
you can plan, you can take action.
Let's get stand-up desks for people, because we got all this back pain for all these people that sit all day long. We can do things like that because it's based on the data, and then have a before and after.
Yeah.
And that's been phenomenal for us as we move forward.
Well,
to save dollars, try to save dollars.
Well, where else in your line of work where you pay a big premium for something and then it increases every year and you get no data to support?
Correct.
Nothing, probably.
No.
You go and find a new vendor that maybe has higher quality or lower costs or whatever.
There's no there's no industry like the insurance industry. There really isn't. Other than some things that I won't say.
Yeah.
We've recorded on here. But there really is not. And it's unfortunate because everybody started out in the right place in the right frame of mind, but as things have transpired due to good old capitalism, it's moved in a direction that is unsustainable.
So what were some of the things that maybe you saw when you were with said fully insured carrier, not only purchasing insurance from them, but also negotiating with them as far as reimbursements go? I mean, how did that go?
So from a provider standpoint or from an employer? From a provider standpoint, employer standpoint.
Obviously, you sit in a seat that's much more powerful than, a manufacturer that doesn't provide healthcare in the community.
You do have, and it's the lens is great because you do get to see both sides of those things. Because you do go, wait a minute, premiums increased 12% this year and our reimbursement went up 2%.
Yeah.
How's that work? Right? And the answer was typically BS, administration. It's an administrative bloat is what it is. Yeah. I mean, that's what you get down to. And again, it's not throwing darts at these folks, because I'm sure they had great intentions when they started. But if you look at kind of cut to the chase, the people taking the most risk in the system are whom?
Doctors.
It's a guy holding a scalpel or making the diagnosis or whatever. They're the most. Who has the least effect of how much they get paid on? Doctors. It's this guy over here takes no risk, but has this great program in place that wants to keep that in place. So what we saw when we were on the fully insured side of things was not much in terms of flexibility with the program. Not really any proactive. It was all reactive. We couldn't get proactive and say, here's our data, we need to do this, this, and this. It was all reactive to, oh, crap, we need to figure out how to drop dollars down. On the provider side, you need a lot more, and we've done this. We've gone out and hired third parties to pull data, so when we go have those conversations with different providers, different insurers, we can show where our cost of care is compared to what you're paying us to try to negotiate. Now, that's where that balance is, and that's really hard, and that's a whole nother podcast of how much does it cost to go to the provider, how much the insurance company has to pay, and where's the premium go in the middle. But are there providers that are charging and overcharging and doing that? Sure, there are. There's us? No. But there's certainly ones out there. But, gosh, it's just so unique that any of the large cities in the United States, if you go downtown, one of the 3 largest buildings in downtown of any city is an insurance company.
Yeah.
Yeah,
I mean, look at the map. I mean, obviously we've evolved as a world and as a country. I mean, we figured out how to create electricity. I mean, otherwise we wouldn't have a tree on this planet right now, right? So we can agree to that. But you start looking at the manufacturing jobs and the rural economy jobs that supported these small towns, these small town hospitals, and the dominant employer in the majority of the states is the insurance industry, which I know they provide a good living, but at what cost to our small communities, which is why we call ourselves Community Connected Health, is we're trying to restore healthcare, we're trying to restore our communities. And I had this discussion yesterday with an insurance organization. I said, look at the cost of medical school. Why is it so expensive? It's because it's a pass-through for the faculty and staff and their health insurance. It's like a tax, right? It's a tariff. And they're going to say, well, our cost went up 10% this year. We're going to have to raise our tuition. So we're just one-upping each other. And so suddenly we have these people say, I can't afford to go to medical school, so I'm going to be an insurance salesman.
I'm going to be a broker.
Yeah. Yeah. Well, I tried musician, but anyway, youtube.com. No, don't do it again. Okay. But the point is you've got to look at the economics of this and see what the impact that it's had, just even on medicine, is that you've got people that don't want to even be in this business because it's such a rat race of complexities, and they're just like, it's like the football player that talks his kids not into going to play football. They're like, oh, no, I want my kid to have that life. And I did talk my kid not into being a health insurance broker yet. So, but you know what I'm saying? It's like we have doctors say, oh, I don't, or kids say, I want to be like my dad. He's always working too hard and just, was always at odds with the cost of things. And so we see this just uncontrollable engine of taking these dollars out of our communities, and it's stifling economic growth and innovation. And so, we just kind of put our foot down. And so I'm going to reel this all in for you, Colton, and say, we want to just put this in plain English. And so when we're building our custom health plan stack, which you've opened yourself up to the big, broad world of other competing orthopedic groups across the country, which is great. And that's what we want to do when we're building solutions. When the nurse navigators are working with patients and working with our clients and the members, they're reaching out to them and saying, hey, Rich, see, you've got this upcoming surgery. And we have in our OVN network, we have a high quality blue chip provider that is going to be able to do that surgery for you. And we've even gotten innovative enough to say, hey, if the cost is so much lower than a larger system or a competing system, we'll also include travel expenses for that. And we build that into the plan. And so we give the patient a choice, because that's the thing that people always are like, oh, you're going to tell me I can only go to my DPC, I can only go to DMOS. I like to go here. It's like, no, calm down. We'll give you the ride you've been on, but we're going to have this conversation with you. And when they say yes to the dress, so to speak, they don't have to pay anything if they're out of pocket. And so that's when it stays in your four walls. And so that not on the flip side, the employer, since they're going to see the data, they're going to see the information, the facts that they've paid 20 to 30% below what it would have been if they had through insurance, which usually is a job.
Yeah, it's absolutely a job. And it is important to understand that most of Iowa are the smaller communities. And that's where we're losing, I think right now, that touch. And as these benefit plans go up, these companies just can't afford it. No. They can't. And we got to figure out a way to make it better for them. And that's what we've tried to do.
Well, and as the employers raise deductibles and, now those patients are walking into your four walls, I mean, how many of them you have to now have a conversation about, payment plans because they can't afford, their $5,000, $6,000. I've seen $9,000 deductibles.
10.
Yep.
Yeah.
And so we obviously call that functionally uninsured. You've
Correct.
got, a health insurance plan in place, but it's really not providing you any financial protection. And it's just a sad thing to see.
It is. And we see more and more of that, unfortunately. We've had a lot of internal discussions. We've reached out to other partners about, okay, so what are we going to do about this? Because this isn't going away. With the companies and employer-sponsored benefit plans, some of the only knobs they know to turn is deductible. Turn it up, turn it up, turn it up. And now where they're at, they just can't afford to get that rotator cuff repaired, their ACL repaired. So we're looking at some creative ways to help finance. The challenge of financing is there's no collateral in healthcare. It's not like we're going to go in and take their knee back out if they don't pay for it. But the backwards part and the business part of healthcare is difficult as well. You don't walk into a grocery store in town, buy all your groceries and say, here's 10%, I'll pay you the rest of it in 6 months. So you've got that dichotomy, and that's a whole nother conversation. But
it's the death of Mayberry, right?
It is a little bit.
Because I mean, I live in Grinnell, Iowa, and I could go down to my True Value, and I know the guys well enough because they want me to get me out of there as fast as possible.
I can't imagine.
I've had some doozies. I'm like, can I take this lawnmower home, please? And you can bill me later. Well, those days are over in healthcare, right?
Yep.
And that's, $226 billion of unpaid medical debt in this country. And so now they're like, hey, we've been able to look in the portal at your carrier, and no matter how you argue as a patient, like, I've already hit my out-of-pocket maximum, they are really only they're not seeing your accumulators. They're just seeing what your deductible is. So I've been told over and over and over. So providers are saying, oh, don't worry, we'll work this all out later. And if there's any dollars you're owed, we'll, write you a check. But people, and you have every right, and you have to at this point because the deductibles are so high. You'd have to shut your doors if you did the Mayberry effect, right?
You can't.
You can't
run an organization that way. Yeah. So we do work with our patients on financing plans. Unfortunately, and I don't have the percentages offhand, that continues to go up.
Yeah. So how about we have the patient get the best care, and we have it on their cell phone. They walk in and they got a digital credit card. It's all been arranged. All their medical records are there, safe and sound, get the best care possible, and they pay zero. And then you don't have to go chase your money. So think about the efficiencies on your business side of that. Your business ledgers,
Now, prior authorization and peer review take up so much time. 90-something percent, high percent, like 97 or 98% of things that go through prior auth are approved.
Yeah.
Then why the hell are we spending all this time on doing that? Yeah. Administratively, it's a bloat. It's a burden. It's a game.
Yeah. Well, the insurance company's job's not to pay money is the answer.
No, as a private practice, we have to pay people to ensure that we were reimbursed at what the contract says it is according to our fee schedule. You know how many times we find they didn't pay $7, $6, $12? It's not like they didn't pay us $400 that you're going to blatantly see. It's all these old nickel and dime things. Mm-hmm. End of the day, it's $30,000 that we didn't collect. We have to pay for people to go back to make sure their systems run right, which is a really difficult thing. Nobody wants to feel bad for the private MSK group in West Des Moines, but we do employ 350 people, and we're going to want to employ more people, but not to do things like that.
No.
Not in the future.
For every doctor, there's 10 people in administration. I think that's the number right now, right? Yeah. We're all in agreement on that. So we're going to try to simplify the system, and it's not just happening in Iowa. This is happening across the country. I think last time I checked the stat or the number was there was 7,000 independent providers across this country that are now doing some form of bundling, whether it's bariatric surgery or if it's a simple general surgery for a hernia tear. Certainly orthopedic is really knocking it out because you guys are self-contained in your ASCs, and that's the big thing. MSK's
easy, dental's easy. Not easy, but it's easier to be able to bundle that up than it is in other places.
Dentists were pretty smart after all. They stayed out of managed care. Yeah, so, yeah.
From your perspective, as you are setting up these kind of like direct agreements with employers, whether that's through, an aggregator or an Ortho Forum, how are you trying to dictate that price compared to, maybe one of the insurance-based models? Because I know we've spoken to other orthopedic groups that have entertained some of these things, and they're skeptical themselves because they don't want to cut,
you don't want to make your price a commodity, right?
Yeah,
you don't want to go run into the bottom.
Employer wants, an incentive to send patients there. We try and drive as much volume as possible. We or eliminate out-of-pocket costs so you don't have to collect that. Try and pay timely. So there's an ROI of all of that. And I know we spoke to a gentleman recently, and he's just like, well, I just don't think I can take a haircut on my costs compared to what Blue Cross Blue Shield pays me. It just doesn't make sense. But you have to think at a multi-prong approach, right?
You do. It's one of those processes that keep you up at night when you first start.
Yeah.
One of the things that opened the door for us, and not to get too in depth with how we set pricing, but you take an average price of where you're getting paid, and that's what you charge, right? And you tack on a little bit of an administrative fee because it does cost to do that, and then you throw in a little bit of a kicker for inflation because everything inflates. You look at CMS reimbursement rates. We're losing money. I think you look at healthcare in general. There's a graph out there that shows that providers have only been, the increase in Medicare rates is like 3% versus 25% inflation. So
this year it's 0.89%. They're going to give you a big raise.
It's ridiculous. But the key to that though, Colton, and this is something that we were really kind of eye-opened on. It was when we were working with some partners on the contract negotiation. Is guess what? Everybody knows what you get paid. It's not like a secret.
Yeah.
So don't think the insurance companies don't go, oh, well, DMOS is getting paid this from company A, this from company B, this from company C, and we're going to set ourselves at 94% of the market or 96% of the market or 88% of the market. So they know what you're getting paid already. That's one. So forget about we're going to tell them our prices and take a haircut, because that's not going to, I mean, they know already they're going to haircut you and you're not going to have anything to do with it. Mm-hmm. The second part to that is, as a consumer, if you buy on price alone, you're going to end up with maybe a little bit less of a product, right? Yeah. So part of setting a bundle, you have to have the quality metrics, you have to have the efficiencies, you have to have those things in place, so that when you put that out in front of anybody, they can come back and go, oh, I can get it for $2,000 cheaper over here. And we're comfortable enough with saying, that's fine, you can go do that. But if you want to stay with us, here's our price. Here's our stats to show why you pay $2,000 more here. Yeah. 98% patient satisfaction, above AAOS standards for all of our outcomes, things like that really matter. So that's where it gets into. And I think in healthcare, like everything, we're 20 years behind. Yeah. We're just now getting in that consumer point of, where do you set prices? And you talk to any entrepreneur, it's hard to do that, right?
And all of that is, I feel like, super important for the C-suite at any business to know as they're trying to move from buying health insurance and buying health care, because they're giving their employees an unlimited credit card in the form of their health insurance ID and saying, good luck. We've always talked about, hey, go be a good consumer, but we've never given them the tools to be a good consumer. Well, most of the big systems, they've got primary care, urgent cares, ERs to consume the patient and then just funnel them up to the expensive things. And at no point does the patient think, well, maybe I should get a second opinion, or maybe I should look over here. What are the cost and quality metrics here versus here? And so sometimes when we're talking to employers about these, care navigations or DPC, they're like, well, we don't want to tell our employees where to go. And it's like, if they're going to have a better experience, they're going to pay less, you're going to pay less. How do you lose?
Yeah, I think part of it too, and this is what we experienced, again, employer hat, was eventually the employees are used to having the unlimited credit card. I'm just going to go here. You can't have your cake and eat it too. Yeah. So if you still want those raises, if you still want your job to be available, you're going to have a little bit of sacrifice on that side as well. So going to this super high cost provider that doesn't have accuracy, doesn't have a quality of data, doesn't have outcomes, things like that, maybe you can't anymore. And I'm sorry, if you want to do that, you can go on your own. But as an employer, we're going to make some sacrifices, and you're going to make some sacrifices. In the middle, you're going to come out to a better spot. And that's what we've noticed over this 3 or 4 year journey we've been on now with the self-insured part. When we first went from fully to self, we looked fully. We paid for a lot on both sides. We could have easily gone narrow network and said, well, whatever, good luck. But we didn't. And now that we're 3 years in, 4 years in, we're starting to pull a lot of that back to decrease the cost of care. I think, I
think that's super important, just because you have to have those conversations with the employees and educate. We do employee meetings all the time and trying to educate the employees on, hey, you are part of a self-funded health plan and this is what it means. But the top, or the C-suite, you, Renee, the rest of the team, need to constantly be educating and re-educating and saying, hey, well, guess what? We're still self-funded. How you use healthcare matters. That, helps our rates and our renewals and
it's a long journey, isn't it? And that's it is. And early, we're building all these super great programs. This will work. And then the employees don't know where the hell to start.
Yeah. Well, and that's really puts the onus on us. And I think that's, as we've talked about brokers out there. And so, I mean, I challenge myself on this, and it's like, we have a duty when we are putting these preferred networks together that sit in front of a traditional PPO, because we want to give choice, is explaining to the employees why this is an important decision for them, that when they go there, they're not going to like the quality of care, but we'll deal with the price later. But price gets their attention out of the gates, and then the defensive mechanisms come up. Well, you're telling me where I need to go, but if I want to go here, and I know I've repeated myself on this podcast, but it really comes down to the first order of business. This is when we have the blessing of the employer. When we meet with those employees, we tell them this is going to be a different kind of conversation. Who is the insurance company starting January 1? Does anyone know? And there's somebody in the room like, oh, Midland's Choice. I'm like, pretty good, I'm not being condescending here. And I'm like, oh, yeah, good. And I said, you are, we are. This is a different ride. So you're thinking that you're sending a bunch of money to a shiny building, I said, we all have to work together. We want to keep the money in the four walls, and we're going to show you ways that you can do this. And that's our duty as brokers. That's where the trust, you're not going to stop what you're doing at DMOS and say, hey, Rich, can you come over here and help us with an employee meeting?
No, but it's part of the employer too.
It's
responsibility to not just do this at open enrollment, and we make an effort, and we're not great at it. We continue to work on it, but to bring that up in all the meetings you have all year long. Mm-hmm. Remember, we have DPC. What's DPC? To the point of they're like, I'm tired of hearing what DPC is. That's fine. At least when your kid has an ear infection at 10 at night and you're half asleep and you're freaking out, you go there. Yeah. You don't go to the hospital.
Yep.
And you save dollars doing that.
Yeah, well, we just did a stat for your group. 86% of your visits in the last year were between 7 p.m. and 7 a.m.
Yeah. Yeah.
Right. And we did the analysis on that.
ER avoidance.
Yeah.
ER avoidance, exactly. So what did that save us? Whew.
Yeah. And then there's the soft cost, which I said you can't put in a spreadsheet because someone's actually showing up to work the next day and hasn't been up all night waiting in an emergency room.
And our poor hospitals. I don't know what the answer to that is. If you walk into any hospital around here in ED, it is just 60 people deep.
It's
8-hour waits.
a never-ending episode of Cops.
Yeah.
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 So,
which I love that show, by the way. It really helps me when I'm working out in the morning. So we're in a wrap-up mode here. But I want to make sure you mentioned Health Rosetta earlier. Mm-hmm. I meant to say at the very beginning, congratulations on your award last year.
That was fun.
Accepting that award in front of 76,000 just
screaming fans.
Screaming fans.
Yeah. Beautiful.
That whole AI thing that Colton put together looked like the place is
just packed.
They had plenty of beer for us, though.
Indeed.
But, so that worked out well. But anyway, congratulations on that. It is a big deal. They don't hand those out like certs.
Well, you know what? If you're going to you're going to talk the talk, you better walk the walk.
You want it as an employer.
You better make sure if you're you need to do that. And it was, we wouldn't, this is the GoFundMe bonus part.
Yeah.
We wouldn't have been able to do it without you guys guiding us through that.
Yeah.
And that Health Rosetta, I highly encourage anybody, if they haven't looked into that, to look into it as an employer. Don't worry about your broker. You read about it in your employer. Read Dave Chase's first book, The CEO's Guide to Navigating
Restoring the American Dream.
Restoring the American Dream. Read that. It is absolutely the playbook for why you're paying more for insurance right now. Yeah. And it's not a lie. It is absolutely the bold truth.
Mm-hmm. Yeah. Well, we're hopefully going to have Chris Deacon on one of these podcasts.
That'd be great.
Yeah. Well, we're setting up another GoFundMe for that one, but she's, as you well know, she's quite the fighter, and that's what I like to hear. And she's got quite the experience in New Jersey. But the other thing I would say, just a quick pitch, is also there's a Free Market Medical Association too, which I think really fits the primary care and the specialty world. Just people that kind of speak their language and how they can get integrated with like-minded brokers. And
right.
I'm safe to say we're not alone in this.
No.
We were on a recent chapter meeting, and you hate saying it was kind of like therapy when everyone's saying, "Gosh, how do we get everyone's attention here?" But again, we go back 4 years, like, oh my gosh, well, as soon as I hear about this, it's just we're going to dominate, and it's just been a slow process. But we're here to fight the fight for absolutely sure on this. And you look at just what's happening in the DPC market space in Iowa, and people are starting to ask us, what are they doing? And that's it.
Takes time.
Yeah, it will, and we'll make it better that way. That way, we're not just flooding the market and seeing that happens. Right.
Well, and props to you, and taking those steps, and Renee, and believing in us, because now that you've done this, you're a model for any other employers, not only in Des Moines but across the U.S. Because Skip and I are always looking for references that, hey, this is too good to be true. But being able to hear from someone that not only works in healthcare but has actually taken these steps just makes things a little bit easier.
Well, I appreciate that, and we've got I would be very remiss if I didn't say we had a very forward-thinking board and a group of physicians that own DMOS that thought along these ways as well. Dr. Nick Honkamp is one that is happy to tote this, and he's the one that really is the Pied Piper of we have to bend the cost curve, and we've jumped right in behind him. So everybody being able to do that has been great, and we will be happy to speak with anybody about our current or where we are currently and how we got onto our journey, because I think it's important to to
Yeah,
stability.
I mean, I've spent most of my career working with providers, and unfortunately, I've heard over and over, XYZ carriers are in their right to screw us, and no one else has. And that's been just a ongoing argument, and they're busy people, and they don't have time to count all the $7 that we're missing in their charge masters. And so, Nick's been great to work with, and he's a fighter too, and he's I'm not. This is going to get fixed, and so he's a fixer, and he fixes people physically, and he can definitely fix them mentally too.
Good leader, good leadership all around. Yeah, it's been great.
Yeah, top 10. Yeah, I think we're good here.
Any final words?
Yeah, you got like a website they can check out your
DMOS.com. Everything done at DMOS is at DMOS.com.
Yeah.
You want to make a virtual appointment. You want to see where the urgent injury clinics are. You want to see the doctor. You want to make an appointment. You want to pay your bill. Everything is DMOS.com.
Yeah,
Perfect.
How far? Just selfishly, what's your regular patients that have come back for a tweak here and there, or whatever? What's your range? I should say your region.
It's about a 2 hour. So. To the we're in Des Moines, so to the west it's pretty much Omaha. To the south it's almost Kansas City, really, because the south is kind of right. We've partnered with Grinnell. There we have a physician, a DMOS physician in the Grinnell Hospital. So
Dr. Tedesco.
Dr. Tedesco.
Yeah.
Anthony's a great guy.
Why is it every time he sees me he shakes his head? By the way, can you work with him on that? Okay.
Yeah, we'll see what we can do.
Yeah. That was my antics when again. No, it's a pleasure to see you again,
Thank
Rich,
you.
and looking forward to a bright future. And we've got a few things to say and demonstrate for the people out there that are working hard in this state and really in this country. So
Agreed.
Enjoy your trip to where were you going? Oh wait, you're working next week.
Yeah, I'm working next week.
All right, great. Well, we're going to sign off. Thanks for joining us, everybody. Please ask us questions. DMOS.com. Check them out. They're awesome, and we love them. So we'll see you soon.